Hi, I'm Dr. Mark Brayman, and I'm going to be sharing with you, my friends and colleagues, a presentation on how to create a successful lifestyle medicine practice. This is actually a presentation that I gave in 2016 May at the Harvard Lifestyle Medicine Conference, and then in the fall of 2016 at the ACLM Lifestyle Medicine Conference in Naples, Florida. Desktop version, which will be better quality for all of you not at the conference. So very briefly, who I am: I'm a physician, Master's of Public Health and Epidemiology, Fellow of the American College of Lifestyle Medicine and Preventive Medicine, board certified in Preventive Medicine and Occupational Medicine. I've done primary care for years, lifestyle medicine focus, and have been involved in the past in developing lifestyle medicine boards, not as much recently, but in the past. American College of Lifestyle Medicine, I was a founding member, second president, first executive director, spent years helping build and grow that, developed and executed the first ever conference on lifestyle medicine practice management, which was part of my journey to this point. My clinical experience: I've done solo, group, hospital-based, primary care, integrative medicine, and I'm currently developing what I hope will be a model fitness center-based lifestyle medicine practice. The important thing is that I am a clinician, and as in this cartoon, the nurse says I'm morbidly obese. So what are you going to do about it, doc? I have to deal with patients just like you do and just like most of us do. Disclosures: really no major disclosures. I've spent a lot of time doing nonprofit work. I've spent the equivalent of 5 years of full-time work during the prime of my career building lifestyle medicine and ACLM. Currently the president of the Lifestyle Medicine Foundation, doing some great projects there. I'm also developing a patient advocacy organization to be the voice of the patient. Patients need a voice. On the commercial side, at the time we made these slides, Lifestyle Medicine Pro was not yet launched. It is now launched, supporting practices and providers doing lifestyle medicine. And lifestylemedicine.com is a work in progress. Hopefully will become a very good thing down the road. And I'm involved in other aspects in developing healthcare as a system. We really need a system, which we do not presently have. I do speaking, consulting, educating, no major financial issues. It's really important. I want us to keep in mind this is fundamentally about people. This is not about money. It's not about medicine. It's fundamentally about people. And how do we provide the kind of care that we would want if we were the patient, or if we're taking care of our own family members? As such, it's really important that we start with this concept of what is a person. And this almost sounds too simple, but it's actually really important. In medicine and healthcare, we focus on the physical level, but it's not just the broken toe in room 3. They are a person. They're composed of a mind, emotions, and they have a spiritual component. What gives their life meaning and purpose and drives them? What is their construct on reality and life? And then, of course, we function in a context, in an environment of people, places, things, and circumstances. It's also important to understand a comprehensive approach to healthcare. I won't spend the time to go through this, but this is a model that I've developed with a lot of effort and over a lot of time. Lifestyle, the science shows, is 3/4 of what causes our disease and should be the fundamental approach or foundation in treating disease, chronic disease in particular. Physiology, relatively natural treatment options with good science, physical therapy, evidence-based nutritional supplementation, etc. Then we get into the pills and procedures, which is conventional medicine. And it's great when we actually need them. We just tend to way overuse them. Our challenge, of course, is that that is what gets paid for. There's all kinds of bureaucracy, paperwork, red tape, but it's where the money is. So if we want to practice a different kind of medicine that uses lifestyle and the whole picture, how are we going to get paid for it? That is the big question. How do we get paid for doing things differently? Now, our challenges with the conventional medicine paradigm that we're in is there's a lot of hassles and barriers, as most of us pretty much well know. And it seems to be getting worse. The complexity, the paperwork, the people you have to hire just to turn the wheels. It's costly, and it's a lot of waste of time. It's also very much contributing to depersonalization in healthcare. It's not that much fun when you have to function like a machine and your office is essentially just a treadmill and a treat 'em and street 'em. And that ties into this lack of patient education, which is really more about lack of patient interaction and contact time. We seem to be treating our electronic record system more than we're treating our patients. We're treating paperwork more than we're treating our patients. We're treating prior authorizations more than we're treating our patients. And it's just not a lot of fun. So there's a rise of alternative payment models. What are these? Of course, cash. Cash is king, cash is simple, but healthcare is expensive and people don't have a lot of loose cash. Direct primary care is a rising model. If you're not familiar with this, it's a direct pay per member per month sort of approach directly between a provider and the patient. It differs from concierge, and the concierge is typically more oriented towards the luxury market, if you will. Whereas direct primary care is what the typical or average person should be able to engage with in a reasonable manner. And then, of course, there's hybrids, mixtures of the models, and how the payment flows. The most important thing in this is that I want you to understand, I want you to take away from this that practicing lifestyle medicine is doable. You can make a living doing this. Now, it's obviously very challenging. The good news is that there are multiple ways to make it work in almost all systems. There's different ways to get paid in how you go about this. So the obvious question is, well, then why don't we see it? Why isn't it everywhere? Why is it that the people that I talk to that try to do this seem to be failing? There are a number of problems. Number one, it's a very different paradigm of care. We don't have standardized guidelines yet. Most people still don't know what lifestyle medicine is. So it will take us some time to get some of this established and in place. It also requires expertise. There's a lot of poor management in healthcare. It is so complex that everyone is just trying to keep up, let alone do a good job. And to do lifestyle medicine and make it work requires a good level of expertise in practice on multiple levels: clinical, business, management, marketing, billing, and so forth. And up until recently, lifestyle medicine practice support systems and services have not existed. We're hoping to change that. Another challenge is that you have to do real business. Now, it's helpful to understand that healthcare, most of healthcare, is not real business. Think about it a minute. Does it work like going down to the grocery store or the department store? Whether it's food or clothing or buying a meal, does healthcare work that way? No, it really doesn't. I mean, hospitals get built on donations and grants. They buy their big fancy equipment on a similar methodology. They do a big fundraising campaign, get matching grants from some community foundation. When you go about to do lifestyle medicine, do it in a very structured, tangible process. Don't look to how things are normally done in healthcare, or you're going to get yourself in a lot of trouble. You have to do real business. Engage the appropriate expertise, identify and utilize resources, such as the AMA guides on medical practice management or starting practice. And on the business side, be very evidence-based and systematic, like we talk about on the clinical side. Okay, so we're covering a 30,000-foot view. We're giving you framework and structure in a lot of this talk, but we're also going to be drilling down into specifics on some specific models and some specific concepts that I think will be most helpful. Fundamental rule is keep your costs down. I cannot tell you how many times I've seen medical systems and hospitals shoot themselves in the foot, and docs trying to do lifestyle medicine or set up a practice, violating fundamental business principles. The numbers must make sense. There's no way around that. Don't count on getting bailed out by some grant just because the hospital does. Do not do normal medical overhead. I can tell you story after story, example after example of hospitals and systems that have violated this, and it has not gone well. Expense mistakes are the most common cause of the death of independent practices. Again, don't dig a hole before you even get started. And keep your options open and your income from other revenue sources working for you as needed. It's really tempting to just say, I've had it, I'm walking away from this craziness, I'm going to go do lifestyle medicine, I'm going to go do my own practice. That's going to create a lot of stress and a lot of hardship for most people most of the time. I encourage people to keep their options open and revenue streams flexible. Okay, so this cartoon, the doctor with the patient in the hospital bed surrounded by a refrigerator, stove, and microwave. I know you were trying to keep healthcare costs down, but what kind of life support systems are these? So this is obviously a spoof on controlling healthcare costs in the hospital. There's actually a lot of truth to this for lifestyle medicine. If we would just use some of these tools and change our fuel supply, it would go a long, long ways towards correcting the causes of disease. Okay, let's talk about the basics of insurance. Insurance is a financial product. It is not healthcare. I cannot emphasize that enough. We confuse healthcare insurance with healthcare. Obviously, it dictates so much of what we do, and it's such a hassle, but it is not healthcare. It is a financial product. And I talk to docs over and over again that are frustrated with insurance. Understand it is not healthcare. It is a financial system, a financial product. It will never make sense clinically. Save yourself the insanity. It should not dictate health practices. Obviously, it has a huge influence, but don't let health insurance be what guides and directs all healthcare practices. Don't let it choke what you would do for your patients. And realize that even though insurance is a highly regulated industry in healthcare, to a large degree, and especially relative to lifestyle medicine, they basically do what they want when they want. And it may take things like taking issues and cases to the state insurance commissioner to get things paid for as they should be. But that's what you have to be prepared to do. Okay, let's cover some common misconceptions and myths. Help you avoid a lot of mistakes that I've seen repeated over and over. If insurance pays, does that mean it's okay? Wrong. Just because insurance pays you for something you submit doesn't mean it's a good thing or the right thing to do. And especially in lifestyle medicine, I've seen many times providers and practices bill for a service that is different than what the code actually represents. The insurance company doesn't know you're doing something different, and they will keep paying it. But if and when they discover that you are selling them oranges instead of apples under the Apple code, they're going to want all of their money back, like right now, and it's not going to be a negotiation. And it's a very unpleasant experience. Okay, if insurance pays, does that mean it's worth doing? Myth. We're going to touch on this in a little bit, but there's a lot of things that insurance pays that's not worth doing, not only clinically, but financially. If it costs you $50 to render a service, apart from making profit, and they only pay $5, that is obviously not worth doing, even though they quote-unquote pay. Okay, next. C, if there is a code for it, that means insurance pays. Again, this is false. Over and over again, providers and clinics will start pulling codes out of the code book and submitting them, trying to get paid, and the insurer keeps coming back and saying, oh, we do not cover those codes. Just because there's a code for it does not mean insurance covers it. Some of you already know this. We already touched on this. Insurance equals healthcare. Big myth. Big problematic myth. And E, if it is taught at a conference, it must be true. Yeah, this is a fun one to present at a conference. No, that is not the case. That is a myth. I've been at multiple conferences and heard well-intentioned people teach wrong things that will potentially get you into trouble. Do your homework, double check your processes, your codes, your billing systems, and so forth. Just because it's taught at a conferences does not mean it is true or you should do it. Now, obviously, we're taking a lot of care to try to teach you things that are accurate and that you can use in practice. Okay, so let's start to dig into this a little bit. Let's focus on private practice, not a hospital system, not a big group, but just simple private practice. There's traditional fee-for-service that you just want to include some components of lifestyle medicine. That's great. There is one model that we're going to talk about, a low-volume, low-overhead model, which is something that I've experimented with. And there are retainer or subscription-based models such as direct primary care And of course, there's always specific programs and out-of-pocket services, basically cash. Now, let's look at this one model. I call it level O, low volume, low overhead, or sort of your basic level 0 kind of practice. Now, this is insurance paid, and only insurance paid for the sake of this model. And we're just going to walk through this, crunch some numbers so you can see what the numbers actually look like. I find it surprising how few docs actually ever see the numbers on the books behind the back. Okay, so let's say that there's a clinic and you just want to share an exam room. Either they're not using it, they have excess space, whatever, but they're happy for you to come in, pay some rent, help share some of their costs, and you get a place to see patients without a lot of headache and hassle. So let's say it's just you, the provider, and a receptionist. And you have an all-in-one EMR, scheduling, billing, patient portal system up in the cloud. Tech support happens automatically as long as you have a good internet connection, which hopefully the clinic already has. You have a very reasonable schedule, basically a typical work week, 9 to 5 or 8 to 5, Monday through Friday, weekends off, vacation days, which works out to about 20 working days per month. And you have a very reasonable schedule. 1 new patient blocked for an hour, 14 follow-up visits, each blocked for half an hour. This is just insurance billed, insurance reimbursed services. This is not factoring in anything else, no cash, nothing else. Strictly insurance for the sake of this model and for the sake of showing the numbers. So what does this look like? You'll notice to the right of the schedule, these are dollar values for Medicare reimbursement rates and private insurance reimbursement rates for the Northwest United States, for new patient and then for return patient. So based on this schedule, 20 days per month, factoring in vacation, weekends, and so forth, if you were seeing only Medicare patients, you would bring in a total revenue of a little over $400,000 per year. If it was purely private, it would be $683,000 or $84,000 per year and a 50-50 mix in the middle. That's the income. What about the expenses? So let's say you pay yourself as the provider or physician a salary of $150,000 plus an allowance of another $50,000 for taxes and malpractice and benefits and health insurance and CME, whatever. Receptionists, let's say they cost $40,000 a year, give or take. Rent, let's say you're paying $1,000 a month for an exam room and the ability to share some waiting room space. $1,000 a month, $12,000 per year. Your EMR, billing, portal, everything system, $35,000. Business support, let's say $30,000, and miscellaneous $30,000. Total cost $336,000. So what does this pan out to in terms of profit? Now again, this is already having paid yourself a salary. So your income is what the numbers were before. Your expenses are the same pretty much all the way across. And depending on what insurance sources you're working with, you're going to have an additional profit of anywhere from $65,000 to about $350,000 after your salary and benefits. Again, this is one model. There's always variations, complications, extra expenses, so forth. But the numbers are actually pretty doable, depending on how you're going about things. Okay, let's change topics here and dig into coding a little bit. Coding clues for success. It's really important that you use the basics really well. It doesn't have to be fancy. You don't have to use all kinds of modifiers and strange codes. You just use your basics, but use them really, really well. Understand how to use them well for lifestyle medicine specifically. And don't forget about time-based billing. Most practices and clinics don't do that because they're so crazy busy. In a low volume, low overhead model especially, or other lifestyle medicine settings, time-based is a good option oftentimes. Okay, so let's look at some CPT code issues. 99213, the equivalent of a 15-minute visit. Here in the Northwest, private insurance pays about $121. Now, the most common appropriate code for those with chronic conditions should probably be a 99214, equivalent to a 25-minute visit. Private insurance pays $179 or almost 50% more. So with paying attention to this, this could make a huge difference in your bottom line and your revenues. Provide good quality clinical lifestyle medicine care, document it well, get paid for it. Time-based billing, you Document the length of time and that you spent over 50% in counseling and or care coordination. This is just a cheat sheet for 99214 with some emphasis on lifestyle medicine. And it basically brings out some highlights on how to adapt, how to focus more on lifestyle medicine kinds of things. So in your history, in your HPI, don't forget the psychological, the mental, the emotional. That's huge for lifestyle medicine. Sleep issues, so forth. Review of systems. Now, in the future, we should have lifestyle medicine factors as vital signs, not only exercise, but other lifestyle medicine components. Until we get there, use review of systems for some of that. Until we get to the point of using the vital signs, use your review of systems to include things like sleep, nutrition, mood, and so forth. And of course, past family, social, history, chemicals, relationships are huge components. Again, focus on and remember the general things, the mood, the cognitive, the emotional sorts of things. And down under decision making in the middle column, RX medication management is actually a big issue for coding purposes. And even if you're not prescribing medication, you should document that you are using lifestyle as medicine and or considering medication and thus managing it. You're managing medication by not having to use it. And then that will help you in your coding and billing. So you may want to print this off as a cheat sheet if possible. Direct primary care basics. Let's walk through this. It's a retainer or subscription model. It's primary care, but potentially a lot more and a lot better. It's not confined to the traditional fee-for-service office visits, which you pretty much have to drag people in to get paid. You can do phone, you can do email, you can text, you can telemedicine. You can do anything that works for you and the patients without being bound to the office visit. On average, patient panels are roughly 500, give or take, more or less. Average cost about 100 per month, again, give or take, more or less. You still need to do proper coding. You need to do staffing, you need to do business management. And in some cases, it's actually more challenging in that you have to do real business. And the healthcare system doesn't just turn like it always turns. You have to create new systems and processes. So what about a lifestyle medicine-based direct primary care? Well, it's personal primary care, number one. It's convenient, unrestricted access. It's a superior clinical paradigm. You're actually treating causation instead of just symptoms and consequences. And you may add lifestyle medicine-specific services. Now, most DPCs include basic labs. There's a lot of variation in what is or isn't included. Okay, let's look at different ways of doing this financially from the patient perspective. How can this work? And most patients don't know this. They don't know their options. And so part of our challenge is how do we educate them on their options and different ways of doing this. So if you were to do only a lifestyle medicine direct primary care service, it may be $90 per month as a single individual. You could combine that with a high deductible health plan and or a health savings account. You may combine that lifestyle medicine direct primary care with a health share service, which we'll touch on in a minute. Well, maybe we'll just touch on that right now. Health shares are an exemption to Obamacare, meaning you won't get a tax penalty if you're using these and you don't have other insurance, that's based on the principle in the Bible of sharing each other's expenses and burdens. So these were set up as nonprofits years ago. They got grandfathered in, exempted from Obamacare, and they're a pretty interesting thing. They are not as developed as the rest of healthcare, but they look like there's a lot of promise. Okay, and there's the potential of using this as part of a participating Medicare Advantage plan. And there are some places and people starting to get some traction with this. So let's look at this. If you had standard healthcare, let's say you're a 60-year-old male, and you're paying $800 a month, you have a $2,000 deductible, you have copays, but with that you get access to specialists. Your primary care is probably going to be a faceless doc. They're going to rotate through, they're going to change, and you have access to hospitals if and when you need them. So there's definitely some advantages. Now, what about a lifestyle medicine direct primary care only? Well, it's great. You've got this wonderful paradigm. We're looking at causation and not just consequences. You've got a personal primary care doc that's not going to be rotated on you. You can communicate however you need to with the doc. You have basic labs included. And it's only $90 a month. But what about specialists? What about if you need to be in the hospital? And what about tax time and penalties? So there are people doing this. They're willing to take the penalty. They can't afford health insurance, so there are people doing this. It's probably not the best way to do it. So let's say you combine that direct primary care with lifestyle medicine with a high deductible health plan and a health savings account. For $800 per month, you can have all of your health care covered with way better care. And when you have to pay deductibles, if you have to use your insurance, it comes out of your health savings account. Now, another way to do this with this lifestyle medicine direct primary care is with a health share. For about $230 per month as a 60-year-old male, you can have all of your health care covered. You would have a $500 deductible, and there are some exclusions, which are not in current healthcare insurance models anymore. So you need to be aware of those, but that's a pretty huge difference financially. You do have to be more responsible. And then there's the Medicare Advantage things that are coming down the pipe. And these figures are credit to Dr. Wayne Dysinger. Let's look at services and conditions. Let's jump over to, if you're going to offer services for lifestyle medicine, either continuing to do what you normally do conventionally and or switching over to lifestyle medicine completely, what would you be offering to your patients? There's actually a lot of things you can do. Alzheimer's, there's some pretty exciting research coming out on Alzheimer's and lifestyle medicine, especially if you can catch it earlier. Cancer, exercise is now recognized as a cancer preventive, prevent recurrence and so forth. A mountain of evidence, it's been a long time coming. But how do you help people optimize for cancer prevention and treatment and recurrence prevention? I'm not saying treatment as lifestyle medicine being the only thing. I'm saying as a supportive thing for treatment, but for recurrence prevention in particular. What about depression? Diabetes, gluten intolerance. Everybody's talking about gluten this and gluten that, and nobody knows if they really have an issue or not. Well, why don't we offer a service to help them sort that out? Answer that question and get on with life. Heart disease, of course, the number one killer. Hypertension, all lifestyle caused. High cholesterol. Interesting things with arthritis. Osteoarthritis and other arthritis is actually the most expensive condition in our system. And there's a lot that you can do for both osteo and potentially rheumatoid arthritis if you use the evidence. Multiple sclerosis, sleep disorders, of course, obstructive sleep apnea, smoking, tobacco addiction, surgery optimization. There's actually some really good science showing that if you do lifestyle in the perioperative period, you can significantly reduce complication rates, duration of hospital stays, speed recovery, and so forth. Of course, weight loss and many other things, but just some things you may want to think through. Okay, what about add-on services? There's some services you may not want to add, such as this cartoon of the grave pit in the exam room with the patient standing 1 foot in, 1 foot out, taking pictures of them to help emphasize how important immediate lifestyle changes would be. Okay, let's look at some real examples and make some decisions here. And it's important to understand as we do this that I'm not talking about just clinical, I'm talking about business. So what about the annual wellness visit that's now 100% covered? Yes, that can be a great thing. You may not make a ton of money off of it, but it is an opportunity for you to go through and do an inventory of a person's health status and their lifestyle issues that's completely covered by the government, at least under CMS. And of course, other insurers tend to follow suit. But if you have other lifestyle services for the things you then identify, that can be great for the practice and great for the patient. What about obesity counseling? Now, should we counsel our patients about obesity? Absolutely. No doubt clinically. What about financially? There's codes for obesity counseling. No. What you will find is that if you do obesity counseling per the time blocks that they allot and get the payments that they pay, you are not only donating your time, but you are paying overhead for the privilege of talking to your patient about obesity. It does not make sense financially. Now, there are ways to do it to provide the service clinically and still get paid for it in a reasonable manner, but not through the obesity counseling codes. What about tobacco counseling codes? Basically the same thing. Our government doesn't seem to think that these things are worth very much. And again, you're going to go in the hole above and beyond donating your time using these codes and these methods for rendering your services. I'm not saying you shouldn't do it. Very, very important. You absolutely should do it, but you need to do it smart. What about ultrasound? I've been looking at this for vascular purposes or musculoskeletal purposes in the context of a fitness center and exercise. I think the jury's still out on this. Some of the costs are coming down, but there's still a lot of barriers. And to do it well and to do it in a way that you would get paid for it, it's a pretty good project. But it may make sense depending on your volume and your patient mix. EKGs. Many people have an EKG machine. It probably makes sense. It's not a big money maker, but if you have other staff do it and you have the equipment, it's helpful for your patients, it's convenient, and it's a good fit with lifestyle medicine. Billable group visits. I want to make sure we touch on this. This is really important and a great opportunity. There are a lot of advantages, and there are disadvantages. The advantages are improved efficacy. People do better in groups. Even people that don't like groups. It's fascinating. The science shows that even people that don't like groups, they do better participating in a group. There is improved patient and provider satisfaction. Everyone enjoys it more. And to be honest, the way we do our office visits today is really weird in the history of humanity. We have never gone into some little cubicle, one-on-one, spent 10 minutes and think that's supposed to change everything. It's just weird. Okay, advantages. Improved quality measures. Quality metrics go up when you do good group visits. Improved access. You can get more patients in on a timely manner. Community building. What I mean by this is you're building group dynamics. This is huge. Again, the science shows that people do better in groups. We don't have good mechanisms in our current system for doing this. Billable group visits can provide that mechanism, assuming you do them well. And you can do as well or better financially if you do them right. So it's not a money loser. It could be a money maker. You can bring in other providers to help with you. And importantly, this has the potential to survive system changes. If payment structures change and you start getting paid for actually getting people better instead of just doing stuff to them, group visits can survive the transition and work well now and in the future. What about disadvantages? It's different. We're not used to it. It means different scheduling, staffing, some patient orientation. It often needs some level of support in an ongoing manner. The guru that really developed this, Ed Nofsinger, and I have talked a fair amount about this, and he has found that practices really need some level of ongoing support to continue to do these well. Doesn't have to be a lot, but something for most practices. And there are some common pitfalls, and some of them are pretty bad. You cannot do time-based billing in group visits. Let me say that again. No time-based billing. You will be committing fraud. You will be in the crosshairs of government authorities, which you probably do not want to do. You cannot do regular scheduling. You can't bring people back twice a week for 4 weeks just because you have a program that you're trying to go through. Again, that's considered fraud, and you will be in the crosshairs. Don't go there, please. And you can't bill for educational processes. You have to use your standard basic codes, 99213s and so forth, office visits, based on bullet point criteria, not time-based, bullet point criteria. You're treating patients one by one. Everyone is benefiting and participating in that process. Now, you can do education in addition. You just don't bill and code and get paid for that by insurance. You just include that in terms of the services you are choosing to render. So, billable group visits can be a great thing. What about program services? Now, there's two ways of going about this. You can do this as core lifestyle medicine programs, where you have a lifestyle medicine program that you basically adapt the different conditions to or fit them into, or you can do a specific program focus. You have an approach or a program for depression, one for dementia, one for diabetes, tobacco, nicotine addiction. So there are these two fundamental ways of packaging or going about this. Neither one is necessarily better. You just need to make it work either way for you and for your patients. Okay, let's jump to another topic, lifestyle telemedicine. Now, telemedicine is long overdue. This model of having to drag people into the office or you really can't get paid to help them is nuts. And telemedicine is starting to give us a little bit of an out, even within the current system. It's being legislated state by state in terms of how the coverage works and is expanding. It's a pretty hot topic these days. 4 different states and legislation. Lifestyle medicine is particularly suitable. Again, you're primarily counseling with people. You're interacting with them. It's psychology. It's education. It's helping them understand the place or comparative role of medications versus lifestyle components and walking them through that. So you don't necessarily physically need to see them that often. But you do still have the same insurance billing constraints. You still need to document appropriately and so forth, unless you're in a DPC or per member per month sort of model. So telemedicine is still developing, but factor it into your services and plans. It is coming. I've been using it in my practice for some time now. It's still not a large volume of my practice, but it could be, and it's a good piece in the toolkit. Future issues. We have a tsunami of technology-enabled and empowered patients coming. If you follow technology, if you follow the leading edge of healthcare and what's going on, there are big changes coming. Not only social media, but a lot of the technology that ties into social media that enables patients to connect to each other, to access more information, to have more systems for data collection and management and so forth. And it's going to be more under patient's control, which I think is actually a good thing. So be prepared for this. Ride the wave. Don't get too far ahead of the wave and crash, but catch the wave, ride it, use it, see it coming. Lifestyle medicine going forward is going to be, I think, at this point, largely shifting to a focus on how do we make this work and be sustainable in practice, financially and management-wise. Getting ACLM and lifestyle medicine going as a clinical entity was huge. It was the most important thing. It's the foundation, but I think we are moving into lifestyle medicine is in existence, it's growing. Now it has to become operationally successful. Now there's good news and there's bad news. The good news is that no system is ever going to make sense unless you are dealing with causation as the foundation of your system, which is lifestyle medicine. The problem is it's a long, slow, painful process. But we just need to ride that out, do what we need to do to survive, and be prepared as the changes take place. And you are part of the solution. We are all part of the solution potentially. And it will take us working together to really make it work well and get there faster. So lifestyle medicine, it's doable, it's worth doing, and it's fundamentally about people and getting the kind of care that people should have access to. So get really practical about this. Write down your next steps. Start to get really tangible. Again, do evidence-based process, but start taking action and figure out what your options are and where you want to go with this. And if you have any questions, here is an email. You're welcome to shoot me a question. I'll be happy to get back to you and see how we can help you. All the best.